Thanks, Jessica. Again, welcome everyone. Good morning. This is the January 8th, 2025 meeting of the Healthcare Workforce Committee. Once again, committee members, if you could put a CM in front of your name, that would be great. We are going to shift the agenda just slightly this morning. We'll go through that. Jessica, if you could go to the next slide, please. And next slide. Couple of things really quick. Once again, this is a public meeting. We are subject to the public meeting laws. Meeting is recorded. There is a live transcription available. Committee members, if you are able to have your camera on, we welcome that because we love to see your smiling faces. But we understand if bandwidth is an issue, which it could potentially be here in Brookings because our internet is not that stable, you can turn off your camera. We also will have a short time for public testimony. We do welcome public testimony and appreciate hearing from the public members, consumers, whomever would like to give it. And next slide. Okay, here we have the agenda. This was sent out in your packet. We're going to review our health equity definition, which we do every meeting. We'll look at the December and January meeting summaries. We will have 10 minutes for public comment. We'll hear from Melina. I wasn't sure if Dr. Hemmings is here. I couldn't see her, but we'll get some Oregon Health Policy Board updates as well as OHA. Then we will tune in to our election for chair and vice chair for 2025. And we've moved committee member introductions kind of down in the agenda a little bit. We did have a new member orientation this morning for our new committee members. So we are going to move committee member introductions down, and we will we'll go through introductions for everyone at the same time. And then we will review the 2024 Healthcare Workforce Diversity Report with the team and talk about next steps. So Jessica, next slide, please. Obviously, this is going to change next meeting. My name is Laura McKean. I am the chair, current chair, outgoing chair. Will serve as immediate past chair for next year. Really quickly, I just want to say it's been a pleasure being the chair and serving on this committee for the last however many years. I've lost count, but I'm really proud of the work that this committee has done. It was really important to me when I stepped into this role, as I shared this morning, that this committee be an actionable committee and not just, I say this with respect, but I didn't want to just be a yes committee. I wanted to be an actionable committee that really got some work done. And I feel that we've really done that. I'm proud of the work that this committee has done with the strategy papers and all the work that went into that and our work groups that we have. So thank you for that. Next slide. Okay. Guests and OHA staff, if you could please type your name in the chat and your role, that would be great. Next slide. And here we have a list of OHA staff that are hopefully in attendance today. I'm sure this doesn't encompass the entire list of folks that are here, but this is who we have. Next slide. Okay, review of our health equity definition. I'm going to go ahead and read this definition. Again, we went over this morning with our new members, discussed it, and discussed the importance of reading this at our meetings. So So Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the following: the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. And next slide. And here is a reminder of our Healthcare Workforce Committee guiding questions for equity framework. I'm not going to read these questions, but you can see here that the healthcare workforce development efforts advance opportunities for communities experiencing health inequities. And these are the guiding questions that we used. Next slide. Okay. Review and approval of the December and January meeting summaries. You did receive these this morning. There were, I believe, 3 different meeting summaries that that we had to approve. I believe there were 2 in December and 1 in January, if I'm remembering correctly. I reviewed them. Can we, Neelam, can you remind me, can we have a motion to approve all 3 at once?
Yeah, that should be fine.
I think we can. Okay. All right. So are there any questions, corrections, concerns to the meeting summaries that you received? Nope. Okay. All right. If I can get a motion to approve all 3 meeting summaries, that would be great.
I move to approve all 3 meeting summaries.
And I'll second.
Okay, committee members, if you could just please, I can't see everyone, so Jessica will have to help me. Please raise your virtual hand or say aye. Okay.
Aye.
Anyone opposed? I have to wait for everybody's hand to go down. And any abstentions? Okay, thank you so much. Next slide, Jessica. Okay, we are at our public comment period. I don't know if we have anyone signed up for public comment. Jessica, did you receive any written public comment?
I did not receive any additional public comment. There was the one written public comment that was discussed at the meeting 2 days ago, but nothing beyond that.
Okay. Do we have any members on the meeting today that would like to offer public comment? Not seeing any hands. Okay. Once again, we do welcome public comment if folks want to give it. So if you would like to do that, you can raise your hand. If we need to maybe offer 5 minutes later on, potentially we could do that. I don't know. We'll see. But as of right now, we have no public comment. And next slide. Okay. All right. We are a little bit ahead of schedule since we don't have public comment. That does happen once in a while. So that brings us to our OHPB and OHA updates. And Melina, if you are okay going ahead with that, we'll turn it over to you.
All right, thank you. Good morning, everyone. Melina Moran, she, her. I am the liaison with the Oregon Health Policy Board, and I'm here to give an update from our yesterday, January 7th meeting. So we started with talking about our new affordability committee and creating this committee with the proposed charter. There was two options to be voted on the committee makeup. So that was voted on an option A. It was what was accepted. Next, we voted on the healthcare workforce needs assessment. Yay, it was accepted and passed. So congratulations for everyone who worked so hard on that. It was a great body of work. So again, thank you. Next, we heard from Dave Inbody, who's the lead for the Coordinated Care Organization contract procurement. This is the largest contract in the state of Oregon for healthcare coverage, covers 1.9 million people. And the reason that we do this is to reset the CCO's expectations. This time, what we're doing different is increasing the voices from the community and the members who have OHP. So it was kicked off, the timeline was kicked off in October of 2024. The CCO selection will be October 2025, and the new contracts will come out April to December 2026. So it does take some time. Next, we had updates from the OHA, and we heard from Ebony Clark, the Behavioral Health Director. She spoke about the Medicaid Certificate of Approval and rulemaking update. There was also, this is in process of gathering community feedback. So there was some public comments focusing on community mental health professionals and their scope of practice. We heard from counselors, CSWAs, and unlicensed mental health professionals and providers. The bulk of the meeting yesterday was a town hall. We heard from OHP members. Oh, and yeah, I just want to thank everyone who shared yesterday, as it takes courage to share, and this information will go into the CCO procurement process. So again, thank you all who shared. Also, I want people's experience with the Oregon Health Plan, the successes, challenges, and experiences, and you could find that information on the OHPB website. We could post that link in the chat if you'd like to give comment. And our next meeting is February 4th, and we welcome anyone who'd like to join. Thank you. Back to you, Laura.
Thank you, Melina. And for committee members and new committee members, I would encourage you, if you have the time during the day, to attend that meeting and listen in. I have, even before I joined the Healthcare Workforce Committee, I would attend the Oregon Health Policy Board meeting. I learn something every single time I attend. It's a very knowledgeable group of people, and you will always learn something. So I would encourage you, if you can, to attend that meeting. And Dr. Chaudhry, I see you have your hand up.
Yeah, thank you, Laura. Melina, thank you for the well summarized update of the meeting of yesterday's OHPP meeting. One of the things that kind of struck me that I was a little bit taken aback on was that the option A that was selected, while it has a strong support of the industry advisory committee that then feeds into the affordability committee with pediatrics, FQHCs, or FQHC representation, behavioral health representation. I did notice that there is no oral health representation. And I was wondering if that was something that you may speak to, or if there's something that can be promoted as a part of, and ensuring that oral health is a part of, at the seat of the table of these types of conversations.
Yeah, thank you for that. Yeah, so it was oral health is not particularly noted in there. I will make sure that there is a seat at the table for that. I can't answer directly if, I don't think it was intentionally left out. But I think it definitely needs to have a seat at the table. I will
Good, thank
take
you.
that back to them. Mhm.
Perfect. Thank you very much. And then, so first off, thank you for acknowledgement of and allowing for an equitable representation at the seat of that table. It's very much appreciated. And then the other thing that I'm not sure if it ties into it or not, I know that our Medicaid 1115 waiver through 27 has promoted the idea of advancing care through the incarceral population or the carceral population. And I also observed in the option A representation that there wasn't a segment of that representation at the seat of the table as well. And if that could be placed into consideration for review and inclusion.
Thank you. I will take that feedback back.
Great. Thank you, Melina.
Mhm.
Is there any other comments or questions?
I do, Laura. I'm not familiar with what Dr. Chaudhry was just referring to, but I have a question about whether traditional health workers are also represented in that list and have a seat at that table.
So this is the beginning of a new committee. And so we have a few members who are leading that, and that's Bill Kramer and Tony German, sorry. And it's the new affordability committee. And so I can get you the documents from yesterday's committee and you can look that over closer.
Okay. And I would put in the event that traditional health workers are not represented at the table, I would put in that request as well. They're a growing part of the healthcare workforce and often are mentioned, but not prominently. So I'm trying to just elevate that perspective.
Absolutely. I don't think each sector of the healthcare workforce was specifically spelled out for the seats at the table, but I will definitely take this feedback back.
Well, thank you so much.
Mm-hmm.
Thank you, Bob. Dr. Chaudhry, your hand is still up. Did you have another question or did you just forget to put it down?
My bad. I'll lower it now.
It's okay.
Thank you.
Any other questions or comments for Melina? Okay, thank you. And now on to OHA updates. Do we have OHA updates for the committee?
Laura, I just wanted to, emphasize again that the committee at a special meeting this past Monday did approve the healthcare workforce needs assessment, and as Melina mentioned, was then enthusiastically approved by the Oregon Health Policy Board, and wanted to thank all of the committee members for your engagement with this important report and all of the feedback that you provided.
Thanks, Neelam. Is Melissa on by any chance? Melissa Yates.
I am.
Melissa, would you mind just giving a quick just a quick summary of the how-to and if you need reviewers? I'm just wanted to see if you wanted to give a plug for that if you need reviewers.
Thank you, Laura. I appreciate that. Yeah. Hi, everybody. I'm Melissa Yates. I use she, her pronouns. Excuse me. And I'm the How To Grant Program Coordinator, and we are in the midst of reviewing the latest round of proposals and would love to have your participation. Excuse me. So yeah, I can drop a link into the chat that gives a little bit more context on what the time commitment would be and our timeline. It'll all be in January. And sorry, guys. Yeah, the how-to program is focused on training programs for healthcare workforce. I'm trying to address shortages and diversify the healthcare workforce. And we have over 100 proposals. So we really need reviewer support and would love to have anyone whose organization is not a part of that pool of proposals take part. So yeah, please feel free to reach out if you have questions. And I'll drop a link to have folks submit their information.
Perfect. Thanks,
Thank
Melissa.
you.
Any other OHA updates, team members that would like to update the committee on anything at all? Not seeing any hands or hearing anybody. Okay, perfect. Next slide. We're a little bit ahead of time. Okay. Election of chair, vice chair. I did send out an email this morning to everyone thanking you for the special meeting that everyone attended on Monday to approve the needs assessment. I also included words again about election of chair and vice chair. We do have a chair nomination, which is Ian, who is currently serving as vice chair. But we do not have any names for vice chair for the committee. I'll go ahead and, like I said, I'll stay on as immediate past chair to support Ian. But if anyone is interested in the vice chair position, can you go to the next slide, please, Jessica? So our committee leadership, obviously, you're going to serve one term as chair, unless you can't recruit anybody to be chair and you get to do it more than once, which is not typical, but sometimes that happens. So if anyone is interested in serving as vice chair, you can go ahead and, send me a message, but we do need to go ahead and take a vote on Ian as chair for 2025. And Neelam, do we feel comfortable as a group doing that aloud? Do we need to have folks send a message to you? What would you prefer?
Yeah, everyone could privately chat me. That would be great with your vote.
Okay. So if someone could just please make a motion to nominate Ian Strauss as chair for the Healthcare Workforce Committee for 2025. And then we'll need a second, and then we'll private chat Neelam with your votes, please.
I move we elect Ian Strauss as chair for 2025.
Second.
Was that you, Surya? Did you second?
Yes.
Okay. Okay. And if everyone could please private chat Neelam with your votes, that would be awesome. And again, not sure if anyone is interested in serving as vice chair. If not, again, I'll be around to support Ian as immediate past chair. And so Neelam, if you just want to let me know when that's done.
Yes, I will let you know. And I think you know, yes, we have enough votes.
Perfect. Okay. Congrats, Ian, even though I
Thank you.
knew this was going to happen. I'm going to change my name now. I'm not chair anymore. Um, all right. So with that being said, next slide, please, Jessica. I get to turn it over to Ian as chair.
Okay. Would it help folks if I kind of gave you an idea of what it was I've done for the last year as vice chair? What's
Great.
involved? Because, I think it sounds like a much larger piece in some ways than it turned out to be.
I think we have time. If you want to do that, that'd be great.
Sure, great. So some of it is when situations come up and the chair is not available in meetings, running this meeting. I'll tell you, the OHA staff are phenomenal at supporting this meeting and have done, every time that's happened, have been really great in terms of pulling that together. We also have a meeting for an hour, 9 a.m. Once a month for the committee leadership. That's going over the agenda, looking at where we're going and what we're going to do in the upcoming meetings, providing feedback to the OHA staff if there's anything they want to hear about from the committee. And then being in the meeting, just being present. If there are sub work groups, sometimes there's work group leadership or at least taking on some other work. That's all that's been involved this last year. Neelam, if you have anything else that y'all are looking for from this, but that's my experience.
Yeah. Ian, did you mention the committee leadership, the chair, the vice chair, and now the immediate past chair, along with Melina as our OHPB liaison, meet once a month to plan for the agendas?
Yeah, I believe I did.
Okay, great.
We also, I forgot something though. We also either attend or review the OHPB meetings every month. So sometimes you can be there, sometimes you have to listen to the recording, but being aware and being present for that. So really, if anybody's interested, it's a great opportunity to be involved, and really helps the committee move things forward.
There are times, like I think the last two OHPB meetings, the chair has presented information to the Oregon Health Policy Board. I think it would be easy to say, oh, Neelam, you do this, but you're with OHA, you do this. However, I think it's important for the chair or the vice chair to be familiar with the Oregon Health Policy Board and engage with them and present the information that that's coming from your committee. I think the health, I don't know from Melina and Dr. Hemming's perspective, but I think it shows the Oregon Health Policy Board that we're engaged in the work that we're doing and that we take pride and interest in it. So, like I said, I think it would be easy to have Neelam or some OHA staff just present the information, but I think it's important for us as committee members and, chair and vice chair to do that.
I guess the question arises, anybody interested? If not, that's fine. We'll sort it out. It's open.
Okay. Okay, and it's all you.
Okay. All right. So, I'm sorry, I'm in Mexico working on a small screen, so it's taking me some juggling here. Uh, okay. So now that we've got a chair, why don't we do committee member introductions? So I can start. I'm Ian Strauss. I use him pronouns. I'm the principal consultant for Ian Strauss Consulting, healthcare innovations work, uh, and have been for many years a senior administrator at a federally qualified health center. Uh, the reason I'm passionate about this work is the same reason I was involved with the federally qualified health center movement for years, is to make sure that everybody, no matter their circumstance, has access to healthcare in all of its many forms. I am going to move along to our immediate past chair. Laura, do you want to do your introduction?
Or Laura McKean. I serve as the Senior Director for Oral Health Services and Community Engagement for All Care. And we're one of the CCOs here in Oregon. In Southern Oregon, we serve Jackson, Josephine, Curry, and Southern Douglas. And one of the reasons I am passionate, I've been in the oral health field for many years. That's all I'm going to say is many years. I don't want to date myself. But I'm really passionate about oral health. I appreciate Dr. Chaudhry bringing up about oral health and the affordability work group. I also try and do a lot of work at the state and national level to make sure that dental is included in Medicaid benefits. One of the tasks that we're also taking on at the national level right now is championing a bill to include dental benefits in Medicare. Currently, Medicare does not have any dental benefits. So we're actually going to DC in May for a Hill Day to work on that work as well. So I love this committee. Like I said, it's been one of the highlights of my time at All Care. And I just think that we do excellent work. So thank you.
Okay. Why don't we, I think I'll call out names just because we've got enough of us now. It gets a little confusing. Elena?
Sure. Yeah, you can stack all the dental people together. My name is Elena. My name is Elena Shablasky. I use she and her pronouns. I think this is my 4th year on the committee. I am a dentist and also serve as a dental director, so in kind of a leadership role for La Clinica, which is a federally qualified health center in Medford, so southern part of the state. And my reason that I'm passionate about healthcare workforce policy and programs, I mean, ditto to everything that Laura said. It's exciting to see oral health being talked about at both a state and national level. But the real reason that I got involved with this is that it impacts my day to day. So like yesterday, I was talking with a coworker about the fact that we have the capacity to hire more dentists, and we cannot do that right now because we don't have the dental assistants to support them. And so that directly impacts the number of patients that we can serve and the amount of access that we can provide. And so I'm passionate about thinking about how we are supporting kind of workforce at every level of the healthcare system. So not just thinking from a provider standpoint, but also thinking about all of the other team members that allow those providers to kind of work in their best and most, I hesitate to say efficient because I don't think we are all about efficiency. We're about quality. So just the best, most quality. You can serve the most patients with the most quality work. And so I think that feels like the truest reason today is that we the availability of the workforce impacts the number of patients that we can serve on a day-to-day basis. So that's why I'm here. Thanks, Ian.
Okay. Alicia Jackson.
Hello, everyone. My name is Alicia Jackson. I use she, her pronouns. I am a family medicine physician with OHSU, but work as medical director and associate program director for a family medicine residency program at Hillsborough Medical Center. I have been a member on this committee for over a year, and it has been very eye-opening and fulfilling to be involved on the state level on specifically trying to expand the diversity of our healthcare workforce. I am wearing kind of a hat of being the chair of our DEIB subcommittee of all of the graduate medical education programs at OHSU, trying to prioritize all of those wonderful things that are unfortunately under attack right now. So I really hope to continue my work on this committee to continue to prioritize those issues. It's nice to see some new faces.
Okay. Koi Vu.
Hi, good morning, everyone. I'm Koi Vu, pronouns she, her, hers. I am the executive director of the Coalition of Community Health Clinics. One reason why I'm passionate about the healthcare workforce, well, it's just representation matters, and it matters not only at this in our workforce, but also in spaces like this with the state where policies are being made, and that diversity of voices, especially those who represent less represented communities are important. So that's why I'm here, and also really also representing the voices of community health centers and clinics that are oftentimes not as represented in these spaces as well.
All right, thank you. Jason Johnson.
Morning, everybody. It's good to see you all. My name's Jason Johnson. I use he, him pronouns. I am a dean of healthcare programs at Portland Community College, and I've been on the committee for, I don't know how long. I think it's at least 6 years. It's been a while. And I joined the committee because of my role in sort of the educational aspect and the pipeline for a lot of different disciplines throughout the state. I wanted to kind of deepen my impact in healthcare to find out how we can increase the pipeline and how we can support the healthcare system in Oregon, which is, everybody knows is struggling a little bit, especially with a lack of qualified employees in a lot of different positions. So I look at my role as bringing a voice to the committee about the education aspect and the education pipeline and the struggles and challenges it presents, and hopefully open that pipeline a little bit more as I learn from other people on the committee and as the policies we create kind of hopefully provide opportunities to expand that pipeline as well.
All right, thank you. Let's see here. Megan Holland.
Hi, everybody. I'm Megan Holland. I use she, her pronouns. I'm the family doctor on the South Coast. I grew up in rural Arkansas, and I have been living and working in rural Oregon most of my career now, over about 20 years. And I'm really passionate about the healthcare workforce policy and programs because I take care of aging rural population that is having increasing health disparities and a rural mortality penalty that is significant and impacted by lack of access at almost every level to care, both primary care, specialty care, mental health services, dental services, even healthcare aides helping people live and age gracefully in their homes. And I think that we need a lot of help, and I think pathway programs are important, but with our population aging, people coming in and out of schools, going into healthcare fields are less and less, and we need to find a way to capture those rural students that want to stay rural and keep them there, and recruit more people to rural areas to provide the care that's needed. Thanks. Oh, I forgot, work is organization and title. I work for Coquille Valley Hospital. That is a critical access hospital on the South Coast in Coquille. And I'm the regional associate dean for the campus for rural health on the South Coast. Sorry about that.
Okay, thank you. Let me see. Molly Reynolds.
Good morning, everyone. So happy to be here. My name is Molly Reynolds, and I use she, her pronouns. I am a program manager with RISE Partnership. For those of you who don't know RISE, we are a labor management partnership organization that works with SEIU and with the state to provide training, benefits, and career pathways for home care workers and personal support workers. The reason why I'm really excited to be here and I'm passionate about this work is that I'm currently piloting a program to recruit new folks into home health care and personal support work throughout. We're starting in Portland and hopefully expanding throughout the state of Oregon. Obviously, there's a great need for this kind of work and an increasing need over the next 30 years. And home care workers and personal support workers are often an overlooked and sort of marginalized segment of the healthcare workforce. So I'm really excited to be representing people and trying to bring new folks into the fold. And of course, this is largely a field that's that a lot of women and folks of color are part of this workforce. And it's a field that impacts Oregonians all throughout the state. So I'm really excited to be here and to work with people who are doing such amazing work throughout Oregon. Thank you so much.
All right, thank you. Why don't we go to Tessa Christensen?
Good morning. I'm Tessa Christensen. I use she, her pronouns. I work for Best Care Treatment Services. We are substance use and mental health across Crook, Jefferson, Deschutes, and Klamath County. And currently I am an executive assistant / contracts manager. One of the things that I am excited about and passionate about doing this is I love strategizing employee engagement opportunities, employee wellness, recruitment, and retention. So I'm really looking forward to this opportunity.
Thank you. Eric Weiser.
Hi, my name is Eric Weiser. I use he, him pronouns. I am a family physician at OHSU, but there I have several administrative roles there. And that is one is I'm the assistant dean of rural undergraduate medical education. School of medicine requires a rural rotation, and that's my purview there. And then I also am the interim director of the Oregon AHEC. Oregon AHEC has 5 regional centers across the state, and our main job is to reduce health disparities through a distribution of healthcare workforce, a more diverse healthcare workforce, and through practice transformation, and enables the healthcare workforce to transform around its community. And so we're at AHEC is really involved in the pathway, everything from really middle school through CME. So the whole thing there. It's very nice to see a lot of familiar faces. So thanks for accepting me on the committee. I've been on the committee for a couple hours now. And the reason why I'm passionate about healthcare workforce policy and programming is that certainly, there are direct links to from how robust our workforce is to how healthy our people are. And while a lot of times, the workforce is funded by the various places, including the federal government or CMS, I do believe that this is a local and state solution and has to be driven that way, so that we can get the right people in the right places and help reduce some of the inequity that Dr. Holland talked about, or people are typically trained in rural places or urban places, but practice in all over, and including underserved places. And so to fix some of those inequities will require state and local solutions.
All right. Well, thank you. Let's see, Levi Anderson.
Hi there, my name's Levi Anderson. I'm with the Oregon Department of Human Services, and I'm a community partnership coordinator. I live in Malheur County and help with community partnerships for ODHS and Grant Harney and Malheur. I use he, him pronouns, and I've only been on the committee for less than a year, so I'm very much in learning and listening mode. But I'm passionate about the healthcare workforce because I think that if we can remove as many barriers and create as many incentives as possible to have those that live, learn, and grow in all the different parts of Oregon to go out and become members of the healthcare workforce or the healthcare workforce and then come back is going to really help our communities to remove health disparities and find what they need.
Okay, well, thank you. Let me see. I apologize in advance if I mix up your name. Surya Karlapati.
Yeah, hi. Yeah, my name is Surya Karlapati. I go by Surya, he, him pronouns. I work at the Oregon State Hospital. As a staff psychiatrist, I'm both certified in general psychiatry and addiction medicine. And I've been doing this for the last 8 years. And obviously, my passion is behavioral health, and that's why I chose this profession. Also, with the going fentanyl crisis and the opioid pandemic or epidemic, whatever, my core focus is also substance use disorder. And in the last 8 years working at the state hospital, I've seen so many of the patients coming back. To me, it almost looks like a revolving door, and I can see with my limited interaction with the community liaisons that there is a huge shortage of workforce that's affecting these patients and their behavioral health care, overall medical health care, and leading that to significant rates of rehospitalization. So I really want to come out of these walls and see what's going on outside and do some meaningful contribution to expand that workforce, or whatever I can contribute towards enhancing that workforce. So we don't see this recidivism and readmission quite often, which we are seeing for the last 8 years, at least in my experience. Thank you.
Thank you. Laura Chan.
Hi, my name is Laura Chan. I use she, her pronouns. I am a new committee member. I'm a student member. I'm currently a third-year student, med student at OHSU. Prior to returning to school, I was actually a psychiatric pharmacist for many years. And so that kind of leads into my passion about being on this committee, kind of my experiences that I saw as a pharmacist. And then as well, I'm in the AHEC program that Dr. Weiser leads, and just finished up a 3-month rural rotation, which was really inspiring and kind of propelled my interest to pursue primary care, as well as working like in a semi-rural location as well, and just being involved in the programs at OHSU with outreach and kind of getting our diverse pipeline of individuals into the workforce here in Oregon.
All right, thank you. Let's see. Judy Geiger.
I'm Judy Geiger. I'm the Vice President of Patient Care Services at Columbia Memorial in Astoria, Critical Access Hospital. I've been on the committee for about 3 years. I think this is my 3rd year now, and my passion is really about assuring we have a strong pipeline of healthcare workers in our rural settings. sounds like I have similar interests from a couple of other people.
Okay, thank you. Gretchen Horton Dunbar.
Hi, everybody. Happy New Year. Gretchen Horton Dunbar. I use she, her, hers pronouns. I currently am a consultant with Mercer. I'm focused on Medicaid. And I joined the committee 2 years ago when I was working for Pacific Source, doing workforce development. And I'm particularly passionate about integrating traditional health workers and increasing access to culturally and linguistically appropriate services, including in our rural areas. So I'm thrilled to work with so many people who share a vision and deep experience and are as passionate as I am about this work. Thank you.
Okay. I think I've gone through everybody who's got a CM before their name. Did we miss anybody?
Yeah, you missed me because I haven't been able to put a CM up. I don't have the squares up. Bob Lieberman. So should I go?
Sure, please.
Sorry about that. I'm Bob Lieberman. I live in Grants Pass. He, him. Currently, I'm the president and lead consultant for Lieberman Group. I've been doing that for about 7 years. And I've been on the committee longer than anybody else who has currently introduced themselves. So that goes way, way back. Jason's been on for a long time, and I was on the committee when Jason joined. So I have a long tenure here, and I've appreciated it through all the years. It's been amazing experience and amazing people who have just introduced themselves or on the committee. For 40 years, I ran a psychiatric residential program that was based, I helped found it. I wasn't the founder per se, but helped found it down in Grants Pass. And at the time I left, we had grown to have a full continuum of services across 15 locations in 5 counties, serving youth and families, youth age 0 through 24, and their families. And through that experience, I really learned a lot. We brought in a lot of great international and national trainers, and learned a lot about the brain science and what trauma-informed care might actually mean, especially in behavioral health. So I have a great passion for teaching that. I do a lot of training on unpacking trauma-informed care and what does it mean not only for our work with the individual who needs some support and some help, but within our organization, for our staff. And I was resonating with the comments about this is about all of our staff. It's not, I think Elena was talking about that, about all of our staff, not just about us who are licensed. I'm a licensed professional counselor, and I do have a private practice in Grants Pass. So part of my passion is applying those principles from the brain science and the actionable aspects of trauma-informed care, such as it's called, to work, especially in behavioral health, but really across the entire healthcare system. And so I really look at my providers and my doctors, the people I work with, to think, are they relating to me in a way that would be called, quote, quote, trauma-informed, or not? I was in the hospital with my wife yesterday, had a procedure on her knee and down in Asante, and I found that most of the people were actually treating me in a way that made me feel comfortable and relaxed and regulated at a stressful time. So that was a really good experience. My other passion, and some of you who have heard me bring this up, including today, may know this, is in my organization, we began putting peer support specialists on our staff and our residential programs in about almost 20 years ago, about 15 years ago. And then we expanded that out to, we had outpatient, we have 0 through 24, we had outpatient, school-based, day treatment, residential for young adults, and psychiatric residential. By the time I left, we had about almost 20% of our client-facing workforce were people with lived experience, in other words, traditional health workers. And I saw amazing results in our measured outcomes as a result of of hiring these folks to be part of our staff. And it got to the point where our staff would say, we'd have a frontline worker in a residential program, a psychiatric residential program, move on and resign or leave or move to another position someplace else. And the staff who were at first wondering, why are we putting on people who have been in the system? Why are we putting on family members and parents who have had kids in the system? often parents are seen as a problem when that's not really a very fair assessment of them. And then the word would come back, please hire another peer support specialist. They do so well with the youth. Things stay calmer. We have fewer episodes. We have fewer incidences of power struggles, which lead to the potential of restraint and seclusion. And so we did. I saw amazing results from doing that. So that's part of my passion for continuing on the committee is I'm going to continue. No one who identified themselves as I'm a person with lived experience. We all have lived experience with the system, but some people identify as, I have been a consumer, I have been a patient, or I've been a consumer for most of my life. I don't identify as a professional. I identify as a professional, but I'm talking about lived experience, meaning people, traditional health workers who identify with their experience in the system as part of their training, as part of their certification, as part of their credentials. So I'd like to see that more front and center. And I think that would help with some of our workforce shortages, particularly in behavioral health, but really beyond and across all healthcare settings. So that's why I'm here. That's why I'm still here. And I sure appreciate the work that everybody does to try to help people in Oregon be well.
Great, thank you. Looks like we still have a few more folks. Dr. Hemming?
Hello, Dr. Hemmings. I use she, her pronouns. I think I joined this committee a couple years ago, maybe, in my role at OHSU School of Dentistry, around that time, focusing on social determinants of health, as it relates to overall health and well-being. Um, of course, since then, things have changed. And I would say my passion about being on this committee, healthcare workforce, is for me, health is everything. Health is more than just physical health. There's mental health, overall well-being, there is social health, oral health, and I really believe that we need a healthcare workforce that is able to adjust and adapt to the changing needs of our community and population in order to have healthy outcomes. I also am concerned about when I say the health of the population, the health of the community, that includes those of us who are actually healthcare providers. And I think oftentimes we, will focus on the needs of those people who are being served, and we don't necessarily see ourselves as also people who also are being served, even though we are service providers. And if we're not healthy and if our health isn't being addressed, then it makes it even more difficult for us to actually meet the needs of those who we're serving. And I think, for this committee, I think we need to always remember to take a look at and incorporate both, right? Not just, trying to meet the needs of, the population that we're serving, but also those who are actually in service to others. So that's my take on that. Thanks.
All right, thank you. Manu Chaudhry.
Hi, everyone. Everyone already took all the good stuff, so I'll try to keep mine pretty cool. So my name is Manu Chaudhry. In full comical nature, I'm a recovering engineer, and also I am a dry finger dentist. I practiced for about 10 or so years, and I've been practicing quite a few years now. My pronouns are he and him. My organization that I have the privilege to serve in is with Capital Dental Care. We contract with roughly 12 different CCOs to provide dental benefits and sometimes the administration of those benefits to the OHP population. And Medicaid is all we do. We don't do anything else. So it's kind of cool and fun at the same time. I've always been intrigued by kind of thinking out of the box when it comes to healthcare and workforce, and how do we build greater levels of interconnectedness. I would like to say that my inflection point was when I practiced at the beginning part of COVID before I joined in the role that I'm currently serving in right now, and practicing through a dental desert, having seen classmates that I graduated with leave the profession because of compassion fatigue and fear of death from COVID. Is pretty impactful, and I believe that the reason why I'm here is to try to make make the world a better place. I think that's a Disney quote, but yeah, that's just why I'm here, and happy to be here. And it's been a really nice journey to experience that with many of the committee members who've been on for the last few years as well. So thank you very much, Ian. Thank you all as well.
Thank you. Rob Ross.
Hi, everyone. Good morning. I'm Rob Ross. I'm a family physician by training. I'm he, him pronouns. I work for St. Charles Health System in Bend as the Director of Academics and Research. Prior to that, I'd had positions as a program director both in rural and big health systems and academia for 28 years, and moving to Bend 12 years ago, I sort of got involved in this for the last 5 years, all the way from AHEC, which welcome Eric, and all the way to National Health Service Corps. And I think my involvement in this committee, which has been for about a year, is just because of the driving force that everyone has mentioned now, and that is education and the pipeline. So having been an educator for many years and participating actively in a malfunctioning healthcare system that is getting worse rather than better, and having had 4 years of being on the other side quite intensively as a patient, and despite my privileged position as having private insurance, being an old white guy and having incredible connections in the healthcare system, it's impossible to navigate. There aren't enough people in the system, all the way from receptionists to physicians, and we're doing not enough to address the problem. And not us as a committee and committee members, because I think we all realize that, but in general, legislators and governments have no strategy to deal with the coming and worsening crisis. So mostly from the education and academic side, that's why I'm here, and trying to encourage the development and push institutions to get more training programs of all sorts. Most recently, having started a rural family medicine residency in Madras, we need to continue. That's just a small drop in a giant ocean of need. So that's why I'm here.
All right. Well, thank you. Thanks to all the community members or committee members. I'd also like to have Melina Moran, our OHPB liaison, introduce herself.
Hi, and I apologize for being off camera. My name is Melina Moran, she, her pronouns. I want to welcome all the new members. Like I said, I'm the liaison between the OHPB and this board. I also sit on the Oregon Commission of Hispanic Affairs. I've been in the healthcare workforce for 20 plus years, and that's pre-hospital, hospital, and in clinic. I was in primary care, currently in addiction medicine. So I'm happy to be here. Like I said before in the orientation, is for years, I've been helping one person at a time at the bedside, and getting involved at the state level, I feel like I could help more Oregonians as a whole. So thank you, everyone.
Okay. So I believe that takes care of our member introductions. Now, just the next slide. Okay, so for our next item, we're going to look to review and approve the 2024 Healthcare Workforce Diversity Report. And do we have, let's see, someone presenting this today?
Yeah, hi Ian. I will present for the Healthcare Workforce Group.
Thank you.
Sure. Thank you, committee members, for having us back again. So my name is Andy Davis. I use he, him pronouns. I am a research analyst with the Healthcare Workforce Reporting Program. Our role, as far as our interaction with the committee, is that we primarily bring 2 reports to you throughout each biennial cycle, where we report both on the supply of the healthcare workforce that was presented and approved in the fall, and also the diversity of Oregon's licensed healthcare workforce. We presented the draft report in December. You've also seen elements of it in the needs assessment, and we're coming back to you today to ask for an approval vote. We have made a couple of alterations based on feedback, either about the needs assessment or directly about the report. And we're happy to have discussion or take questions today. But part of the role of the committee here is by your charter to do review on this report and then to move it on to the Oregon Health Policy Board. So if you approve the report today, we will be planning to present, we'll send it on relatively immediately, but we will plan to present to the Oregon Health Policy Board in April on the body of work that we've done for you as a committee, including the supply report and the diversity report. So if we could go to the next, I'll mention here, I'll be presenting today, but our manager Piper Block and our other research analyst Meredith Howling are on the call today as well. If we do questions in discussion, Piper and Meredith may join me. So we mostly got feedback that warranted changes anyway, immediate changes on one particular figure in the report. So if we could go to the next slide, I'll talk through what we ended up doing on that figure and a little bit on the footnote for the figure itself. Next slide. There we go. So both you may recognize this from both reports. So one of the functions that we serve is that we feed data to the needs assessment. And there's a larger version of this, or maybe more accessible than what's shown on the PowerPoint on page 14 of the report that was in your packet. So we got some feedback on this. Dr. Hemmings, I think you were spearheading some of that feedback about what threshold we chose to use for the highlights of this table. We did change back to the former threshold, which was 2%, or excuse me, for 0.5%. Our threshold that we presented in December was 2%. So that changes a bit about how much of the material here or categories here are highlighted. This is in line with previous reporting we've done, and we also added a note in the caption here about gender categories being non-exhaustive. That's explained in the text of the report, but we had some questions about the fact that we only listed female and male here, and we do collect a little bit of data, self-reported data about other gender categories. So we wanted to mention that and point people to the text where they can read more about that. Those are the substantial changes that we've made between December and now. There are some minor text changes. I will signal to you that we got some feedback just last week from our Equity and Inclusion Division. We expect to make some changes based on their feedback as well. I wouldn't characterize them as substantially changing the report in any way. There are some things that I would point to for changes of emphasis, like the Equity and Inclusion Division intentionally, as we've moved to Real D, we're trying to emphasize disaggregated race and ethnicity categories. I think they wanted us to change some of the language we used and sort of the approach. So I think the biggest example is that we talk often in the report about overrepresentation of Asian, the Asian group in healthcare professions. And then we follow that up with discussion about in the disaggregated populations that make up that Asian group, that it's not monolithic. And they're asking for us to sort of change the order that we present that, so that we talk about the non-monolithic nature of that before we get into just saying it's overrepresented as a whole, as a category. So I expect us to make some text changes, and there will be one change of ordering of a couple of figures. So we have a figure that presents what we would call the group or parent level race and ethnicity groups, and then we follow that up with a figure about subgroups. I think we'll flip the order of those so that both figures will still be in the report, but we will present the subgroups, that disaggregated data first. So just a signal that I expect that to change as well. We're happy to take questions, but as far as process here, we're hoping that you will entertain a vote on passing this draft, so that, as I said, we can move it on to the Oregon Health Policy Board and present to them. If you have other questions or comments, or you'd like to explicitly ask us for other changes, that's possible at this point as well. We'd be happy to have that discussion.
Okay, committee members, any questions or comments for the team?
I do want to acknowledge too, we did get some feedback from Melina Moran, your Health Policy Board liaison, and I'll just acknowledge that our report doesn't do a lot of prescribing what should be done about the way we're seeing diversity play out in our healthcare workforce. We rely on either you as a committee or bodies of work like the needs assessment to make those prescriptions on what sort of policy should be enacted going forward. If that's a direction you would like us to explicitly take, I think that's maybe a longer discussion, and we've got 2 years before we produce another one of these. We could possibly talk about that and make that sort of change. But right now, this is mostly a descriptive report about what we're seeing in the workforce, as opposed to something suggesting ways to change the workforce.
Andy, it's Rob here. Just wondering if there's a way, thanks for all the work on this. And I appreciate the diversity report and the way it's structured. I wonder if there's a way to include folks who come from disenfranchised rural or counties or areas outside of Portland Metro or the Willamette Valley, because, you know, unlike lots of Oregon in the Willamette Valley, the diversity is much less in the rural areas. And, you know, one way of measuring some diversity in that population might be from high school graduation zip codes or some other way. Can you think of any way that might be included in the next report?
Sure. So we relatively often get some requests around, and maybe we want to differentiate here, but we often get requests around geographic dimensions. We did include some new material that's in the appendix of this year's or this biennium's report, breaking down by county and race ethnicity. Hopefully that's helpful in this direction anyway. I think we can try to include, if it's helpful, there is some data that we've worked on a report with HEC, the Higher Education Coordinating Council, on nursing education and the pathways to get there. And there is some very interesting data around the inertia of the education educated population and how they stay in areas where they're educated and how that plays out in the healthcare workforce. If it's desirable to the committee, we could try to include material like that in future reports, if that's assisting.
Well, for me, it'd be very important because you just mentioned the literature. The literature in medical education is really, really clear. The more likely you are to return to underserved and rural areas if you grew up there or lived there or spent part of your training there. So it's a pretty strong relationship. And so to me, if one of the major areas we're trying to address is like maldistribution of healthcare providers of all types, that would be very interesting to see, because I suspect if the data could be determined, it would show the same thing. And how do you address that, right?
Yeah.
Okay, Ross, I think we're gonna, Rob, I think we're gonna have to move on because we got a few more going. Manu, see your hand up?
Yeah, thank you. So really nice report. Thank you for review, your team and as well with putting it together. With what we have here, it's a very on table one. It's extremely comprehensive. I think what I would have liked to have seen is kind of an overlay of age and disability in the cross section that we're reviewing right now. And I really only became attentive to it at yesterday's OHPV meeting. One of the public comments was performed by someone who described herself as having disabilities and also being of a non-Caucasian race. And so as we think a little bit in more depth at all these different connections that there are, I think it would be nice to have that representation or that additional layer, sub-basement layer, you could say, that goes a little bit deeper and is a little bit more descriptive on any potential connections between that as well. So, but overall, nicely done. Thank you for your presentation.
Manu, just to make sure I understand, you're looking for and I heard that public comment as well, and it was striking. You're looking for intersections between disability and other parts of the report in
Yes.
future reporting. Okay.
Yes, that's correct, and also with age as well.
Thank you.
Yeah. I did see that the disability falls into 6 basic questions that were there. I do feel though that I had served on metrics and scoring for a minute, and the definitions of disability that were likely taken from these questions were defined back in 2005 in terms of what disability means. And I feel as though that the definition of disability is far more broad and inclusive than just those 6. So I think it would behoove us in future iterations of this report to also broaden that understanding, since we have such a very, our community is just so diverse. So if we can also look at inclusive of other components of disability in this as well.
Thank you for that. I will note that was also feedback we got from Equity and Inclusion Division, that that question set is it's a few years old at this point that we're using, and they would like us to expand that as well. So that may be happening. We'll be seeing what we can do about it.
Perfect. Thank you.
All right. Alicia, I see your hand up.
Yeah, thank you. I really find this table very interesting, but one kind of glaring thing to me that I feel is missing is medical assistants are not captured under the medical field. And just from real experience, that is one of the, I think, biggest cruxes for our ability to provide adequate medical care. In a lot of clinics, there was a mass exodus of all types of healthcare professions, but if you don't have adequate staffing with medical assistants in an outpatient setting, it can really shut everything down. And so I wasn't sure, if you had data on medical assistants that just you collected and didn't include, or was it something that you guys don't have any data on?
That is and maybe we can have future discussions about this. So what's included in the table are the licensed professions that we currently survey. If it's chosen to expand to certified professions, we can certainly do that. Yeah, I think
Yeah.
that's a larger discussion outside of. So we're collecting based on statute at this point. It's a larger discussion for us to include new professions unless they fall under a licensed group like dental therapists will be a profession that will be included in the future.
Yeah, I guess I would strongly advocate for that just because medical assistants are a very large patient-facing service that most of our patients, that's who they interact with, and having adequate representation from an MA level is extremely important, I think, for multiple reasons. And like I kind of look through here, you have occupational therapy assistants, you have lots of assistants that are basically like the equivalent to a medical assistant, but it's just a certification rather than a licensing, but to me function at like a very similar level in that kind of physician, medical assistant, or clinician, medical assistant dyad that is really, really important.
This is Jason. I just second that. There are several other disciplines that are not state licensed or nationally licensed that are certified that it would be great to have information on besides medical assisting. There's lab professionals, there's phlebotomists, there's some others.
Okay, so I want to thank everybody for their comment. I do want to respect everybody's time. We are at 2 minutes, I believe, before the scheduled end of this meeting. So
I think we're supposed to go till 12:30. So
12:30?
we still have time. Yeah.
Oh, good. Okay. In that case, let's go to Molly.
Yeah, hi, thanks so much for this information. It's wonderful. I just want to kind of tag into what Alicia was saying when it comes to home care workers. I know that they're not licensed in the same way that these fields are, but maybe some inclusion as far as representation of who isn't, who's in home care work. I think it wouldn't be surprising data. But I do think it would be important in the future in any kind of research to include those folks, as they're often, again, an overlooked and marginalized part of the healthcare workforce. And also they're often sort of an entry point into the nursing field as well. So it would be interesting to see. Again, I don't think the data will be very surprising. I think you'll find most of the home care workers are female, African American, Latinx community. But I think it is important to give voice to those folks in the data and in the public record so that we can begin to address the recruitment strategies and career pathways. Thank you.
Okay. Any more comments or questions?
Ian, I might say a word about the last couple of comments if you'll allow it. Just I do want to acknowledge anyway that as people who are interested in this data and also passionate about a healthcare workforce and what we're reporting on them, I think our program would love to have that data. And as I said, we're constructed to really concentrate on the certified workforce, healthcare workforce. If it's the desire of this committee, and I think especially that desire communicated to the Health Policy Board to try and change the situation that we work under, professionally, I think we'd love to have that change made so that we were bringing in data from other parts of the healthcare workforce. And maybe that's a role for the committee to play to make that recommendation to the policy board. Independently, we can suggest that to licensing boards and other folks that we work with, but we're likely to stick with this set of folks unless change is pushed from outside of our particular team.
Okay. Neelam, I see you have your hand up.
Yeah, no, thanks. I also wanted to mention that the healthcare workforce needs assessment does use the healthcare workforce reporting data on the licensed workforce and then uses other data sources to represent some of the workforces that were mentioned, like the Oregon Employment Department data, the mental health addiction and certification board data, MACBO data. I think the issue is that you don't have one complete data source, and so that's why we're drawing from different data sources to try to get as complete a picture of the healthcare workforce as possible, but there are limitations.
Okay. Surya.
Oh, sorry, you're muted, Surya.
Sorry about that. Yeah, I got to leave in a minute, but I felt it's important and it's a great topic. I don't know how much we can bring data from schools. We know for sure we have a certain number of schools that engage in giving these certifications. It's limited. We know for sure precisely what these schools are in the state of Oregon. So I don't know if we can get any data from schools, how many people are graduating, and compare that when we expand this database with how many are we retaining as a state. I'm not sure. I thought I'll just add that point before I leave. Thanks.
Thank you.
Thank you, Surya.
Yeah, Neelam, I'm curious, since I'm hearing this from a number of people on the committee, is this a time we might want to, as a committee, make the statement that we'd like to see a fuller data set as Andy requested, or should we wait for some other time and look at that in a more structured conversation? Piper, I see your hand up.
I thought I would just jump in regarding the data collection process. So just in terms of our role as the healthcare workforce reporting program within Oregon Health Authority, our work is really driven by, directed by statute. So we have the authority to collect this data because statute directs us to do that. And that is the way that we get a very full data set that of specifically licensed healthcare workforce. And so I think this discussion is so great to start thinking about how we might collect data that's broader than this very specific, very technical, statute-directed set of workers that we know is not comprehensive. And like the question of who is licensed and who is certified is like pretty specific to the profession. As folks have mentioned, like maybe there's certain assistants who are certified in one profession but licensed in another, and it doesn't really directly relate to whether like what kind of role they play within the profession itself. So just to explain, like in order to make changes, it's possible that there would need to be more resources for our program, or that the resources come from outside, and that potentially statutes change, and those are pretty big undertakings. So just to kind of like set expectations about what we currently have the authority and capacity to do with our program specifically, but then we love this discussion. We want to have it. We want both our program and our reports to be more useful and inform this discussion in a richer way. So I just kind of wanted to weigh in there. I'm happy to also answer additional questions.
Thank you for kind of setting expectations and looking at where we can go quickly. I'm more I'll carry this conversation outside of this meeting, I think, unless folks have more. Coy, do you have something?
Yeah, just a quick just feedback and recommendation. Just as Oregon is now required for collecting real D and SOG data for our patients, I think it would be great for us to also reflect that in our providers as we're doing surveys and then also, you know, reports like this. So that way it's reflective of the patients that we're serving. And then also I understand that there's, you know, a committee or a process right now to make that list, the SOGI and real D data, even more comprehensive and inclusive. And so, like what you were saying before about the Asian population, if you look into the nitty-gritty numbers of those, there's certain populations that are still underrepresented, not only in our patient population, but also in provider population. And that's the same way what I would say about the Black communities as well with the African populations. And so I know that that feedback has been given, but just also something to recognize.
Thank you.
Okay. Any other questions or comments? Okay, looks like we are.
Ian, just as a reminder, we need to vote. If the committee is feels comfortable voting on this, yeah.
Yes, I was going to say, do we have anybody who is willing to propose that we approve the report as presented?
I'll move that we approve the report.
I'll second.
Okay, we have a motion and approval. If folks would raise their hand or give us some sort of sign that we can move this forward. Okay. Okay, let's lower our hands, and then do we have any no's? And any abstentions? It looks like the committee approves. Thank you.
Thank you, Chair. Thank you, committee. Thank you for the continued feedback and support of the report.
All right. And let's see, I believe, let's see here. Thank you all for a great piece of work. That's been quite a bit there. All right, I think we're down to closing the meeting. Our next meeting will be February 12th from 9:30 until 11 a.m. And, you know, definitely we want to thank you all for some great work, Yeah, thanks everybody.
Thanks, everyone.
Hi, I have a question about the time of this meeting. So today it was 10:30. Is the meeting, because I had this meeting on my calendar for 8:30 and I had 9:30 and 10:30.
Yeah, it's a great question, Dr. Hemmings. It's because this morning we did the new member orientation. And that was optional for continuing committee members. And so when we do the new member orientation, we have a later start for the regular meeting.
So this meeting is 9:30.
It normally is.
Not 8:30.
Yeah.
I had 8:30, I had 9:30, and I had 10:30.
Oh, I don't know why you have the 9:30, but the 8:30 meeting was the orientation meeting, which was optional for you to attend. I apologize that you still had the 9:30 meeting.
Okay, so this meeting is 9:30 going forward.
Yes.
Okay, great. Thank you. Have a good one.
Yeah.
Bye.
Okay. Thank you.
Okay. Thanks, everyone.
Molly had a question in the chat, but Molly, normally